Over the next half hour, I'm just going to try and cover quite a number of things. Just make sure we're on the same page about what we mean by domestic violence. Talk about how it impacts on families. Talk about the effects particularly on mental health, and then identification and response in primary care. And just talk about some collaborative opportunities if any of you are interested in this area. And when you'll have heard a lot about domestic and family violence lately in the press, and family violence refers to any abuse or violence in a family, including elder abuse, sibling abuse, and of course child abuse. Whereas domestic violence is usually referred to as by a partner. And in a lot of the research literature, it's called intimate partner violence to actually identify who is the domestic in the domestic violence. And many of us see it as a spectrum with violence against women and sexual assault. I'd like to acknowledge at the beginning that men and women can be victims of domestic violence, but women have a greater effect of domestic violence. They have greater severity, they have more injuries, they have more fear. And so mostly what I'll be talking about today is where women are survivors of domestic or partner violence. Many of the principles can apply to men as well. So really it's a broad spectrum, and it can also be in same-sex relationships as well, and it's incredibly associated with child abuse. I begin a lot of these talks by acknowledging that there'll be people in the room who've been touched by this issue, and I hope whatever I say is empathic to your experiences. We know the prevalence, it's not really going to be just outside this room, it's going to be in this room as well. So when we're talking about intimate partner violence or domestic violence, the World Health Organisation can guide us by saying it's any behaviour within an intimate relationship that causes physical, psychological or sexual harm. And many of us will be aware of the physical violence and sexual type violence, but it's often the psychological abuse that women feel is the worst, where intimidation and also controlling behaviours, where they're isolated from family and friends or their movements monitored. And more recently, of course, and particularly in our younger populations, the technology-facilitated abuse, which is the use of technology to humiliate, stalk, monitor partners, including sexting. And also described more recently as reproductive coercion, threats or violence against a partner's reproductive health or decision-making to start or end a pregnancy. And also in the mental health area and substance use coercion area, to undermine their sanity or sobriety, control their medication and treatment, and sabotage their recovery. So really when I'm talking about intimate partner violence, I'm talking about a broad range of behaviours that can happen. Now, when we think about just the physical aspects of violence, I think often these things get mixed up, and this is a typology that's been developed by Johnson. So common couple or situational violence is not connected to that general controlling behaviour, arises in a single argument where one or both partners physically lash out. And certainly if you just ask men and women, have they pushed or shoved their partner, that's almost equivalent without any context around it. In terms of the intimate terrorism, and you may have seen in the paper that Rosie Batty, who recently lost her son to family violence, is urging family terrorism is what the term she's coining. And it's a general pattern of control by one partner over the other, and is probably more common than common couple violence. And then, of course, people can use self-defence or violent resistance, where, again, it's perpetrated by victims against their abusive partners. And people have put forward this power and control wheel. There's seats up the front. Just come and have a seat. Where essentially the physical and sexual violence is behind the power and control, but it's actually using economic abuse, using male privilege, using children, using isolation and coercion and threats. And that actually reinforces and makes mostly women fearful. So if we look at the domestic violence prevalence in the community, we think we hear figures, but the World Health Organisation has done an excellent job of looking globally, and 1 in 3 women have physical or sexual violence by a partner lifetime, and the range is from 15 to 71%, with a high prevalence in areas like Africa and India. In our national survey, we're towards the lower end of that range, where 17% of women and 5.3% of men have had it in their lifetime, and a smaller number in the last year. It's a sad indictment in our country that the majority of Indigenous women have been abused as a child or an adult. And disabled women and culturally and linguistically diverse women also have a high prevalence. And if we look at sexual violence, many of us may have daughters. We often worry about them going out and being raped by a stranger, but in fact 50% is by someone that they know and 25% is by a current or previous partner. So even sexual violence is not, just strangers. And why is it important? We know that women die at the hands of their partners. We know it's got large annual costs, mostly to do with the mental health. And it's the leading contributor to death, disability and illness for Victorian women. The study was done in Victoria of childbearing age. So I just want you to turn to the person next to you and just have a little chat about how common it is in your experience and how much education you've had on it. You only get like a minute or two, so go. Keep your hand up if it's 2 hours or more. 4 hours or more? 8 hours or more? 2 days or more? Oh, Rian's going to keep her hand up. Okay. And this is as common as breast cancer, asthma, diabetes, and is the leading contributor. And there's no difference if I'm talking to general practitioners or general practice registrars or psychiatrists or psychologists. It's the same education. So now that you've thought about how common it is, I'm going to just give you some figures from general practice, and some of these from our general practices in Australia. If you look at the push and shove level of prevalence, you can see across the lifetime is about 20%. If you look at the 12-month, it's just under 10%. I was really interested in this because I was working in West End in a touchy-feely general all-female practice, and I wasn't seeing anything like these figures, the same as probably some of you. And I developed a scale, and I just want you to look at the severe combined abuse one, because no one argues with me that this isn't abuse. Locked in the bedroom, kept from medical care, had a knife or gun used against them, raped or not allowed to work. I then, and I've done this several times, certainly in Brisbane but also in Victoria, I took that scale and gave it to women in the waiting room, quite large numbers of women across a lot of practices. And essentially, if you look, that 4.4%. So if you had a waiting room full of people, 4.4% would have experienced one of those items in the last 12 months. Okay, so the next time you're passing through the waiting room. So that's up to probably 2 or 3 women a week for a full-time GP. So it's very common, and I'm hoping I convinced you of that. Another group have the physical and emotional abuse combined, and some women have physical abuse alone or emotional abuse alone. There's a seat up the front here if someone wants to come up. So how does it impact families, and also then what can we do about it? So how do women and children exposed to DV present in clinical practice? Does anybody just want to yell out? How would they present?
They might be frequent flyers for something else.
Frequent flyers, yep. Physical illness, like chronic, yep.
Yeah.
Pap smear, just about anything, but if it's going to be linked to it, what do you think is the most common? Mental health, absolutely. So these are the general indicators. There is some delay, there is some multiple presentations, as someone just said, accompanying partner who is over-attentive, recent separation or divorce, it's extremely high in that group, and if you also know about abuse in their past or in the family. But it's the non-physical, it's all the mental health symptoms that are really, really common, as well as our chronic physical conditions, some reproductive ones and some chronic diarrhoea. And children, of course, are affected, so they present with the same psychosomatic type things. And all of us can see families, we can see these patterns building up where there's bedwetting in the child and there's depression in the mother and etc. And in teenagers, the drug and alcohol abuse. So as one rural female doctor says, I had one just recently, how old was she? 7, and this mother was saying very clearly it's not affecting the kid, and yet she was a bedwetter and she had lots of the classic symptoms. She said, well, I hate it when mummy and daddy fight. And then I said, what do you do? I hide in the cupboard and I take Jack with me. She had this whole behaviour, a way of protecting herself and her brother, who was about 2, of getting into cupboards. And so the main reason I'm here is to try and break this cycle of children having to experience and witness this sort of behaviour. And men who use violence actually present in general practice. We think there's been less research on men who use violence and men as victims, but they probably present with very similar range of problems. And as I'm just reinforcing this connection with the post-traumatic stress disorder, depression, anxiety, suicide and drug and alcohol. So people who you're seeing with that, everybody should be being asked about it. Okay, so then how do we identify it? We know that women have a lot of barriers, or victims have a lot of barriers to disclosure. They feel ashamed, they fear the abuser, they think it's normal because they come from families where it's happening, and they hope he will change. And they fear judgmental attitudes from you, and sometimes they get them. So that's why they don't disclose. I used to go telling them that I cannot sleep. What I'm hoping is that they're asking me what is wrong. I think I'm scared to tell them sometimes. I don't say it's hurting here. They don't ask how the hurt came. And I think that was because the fear of being denied that it's happened. Many, many women just think they're not going to be believed. So what stops you asking about domestic violence? Again, I just want you to turn to the person next to you and think about a patient you might have had with any of those symptoms and what stops you asking. Just talk to the person next to you again. Come back together. I already heard time from the front row here. Okay, other things? Do people want to yell out? Time constraints, yep.
Experience to manage them.
Yeah, so if you haven't been taught, you know, it's difficult. Yep.
Not knowing how to ask the question
Yep.
at first.
Yep.
Yeah.
Some-
Physical presentation, you know, they're not
Yeah.
going to come in with a black eye and split lip.
No, they're not. No, they're not.
Normal like we do sitting here.
That's
It's all
right.
never even into your mind to think, oh.
Yes. So maybe after this talk, that will change your mind, hopefully.
The other
So-
one is having the partner present.
Yes, and that's really, really common and is quite difficult sometimes to separate them. But yeah, you're in good company with other health practitioners, lack of time or skills, belief it's not common. Some people fear offending the patient. Some people fear the perpetrator, especially some female practitioners like yourselves, and belief it won't change anything because the patient often returns to the relationship. And Carol Warshaw is a great psychiatrist in the US, and she says you may also find it difficult to tolerate the pain and helplessness they feel when patients talk about their experience or when their own traumatic experiences are evoked. I think it's probably something that scares most of us, especially if it's something that's so current in a person's life. If somebody walks in and they're suicidal or they're psychotic, you can make them safe, you can take the controls and send them to hospital. This is different. If somebody is unsafe in a way, you have to sort of help them to make themselves safe. So it's a challenging issue about own experience, trouble believing the prevalence, gendered nature, what it means to be a man and a woman in society, and painful to listen to and sometimes feel as if you can't help. But really, women are wanting very simple things. So maybe just quickly again, what would be your first question or several questions that you might ask, how to ask about domestic violence? Again, just talk for a minute. Question that they think you might ask? Do you feel safe at home? So safe's a great one. Another one?
Are you afraid of it?
Yeah, so those are the two that I really, really like. And I think that they're excellent questions. We've got it back, thank you. And so I think what we try and talk about is funneling, so how are things at home? But you might get the answer, fine, you know. But the body language is telling you, or something's giving you, you know, the constellation of symptoms in the family, and I think you've got access to looking at that, and you do see women and children, and sometimes the men as well. What happens when you argue? Because, you know, although it's not necessarily about arguments, it's often indicative of what can happen. And then I find you often have to ask directly, has your partner ever physically threatened or hurt you? And violence is very common in the home. I frequently ask my patients, you know, or say a lot of women who have depression, that's sometimes linked to what's happening at home, including abuse and violence. Is that happening to you? And we know that if you ask that directly, then that's much more likely for women to tell. And certainly in the mental health area, you know, asking about has he ever called you crazy or done things to make you feel like you're crazy, or told family or friends or others you're crazy, or influenced your medication or drug use, or prevented you from accessing help. And the things that assist women to help are very simple. That you listen, that you look non-judgmental, some perception that you might be helped, that you might be confidential, and asking her directly. So in this is GP study I did. If the GP had asked, 80% of women had told. If the GP hadn't asked, 20% of women had told. So it's really a very direct thing. And we also know that women are not going to be offended by being asked. So far I've said it's common, I've said it's got great health effects. So then you might ask, well, maybe we should be asking everybody whether they're coming for a pap test or whatever they're coming. Or should we be asking when we think that there's symptoms? And screening means, you know, a checklist and asking everybody. And really, I'm involved in a Cochrane screening review, and we're just updating this actually. And really what it shows, it does increase identification of survivors from a very low level to a less low level. But it doesn't increase referrals and doesn't influence how women are experiencing violence. So at the moment, we can't say that you should be screening for everybody, but we should have almost what's a very high suspicion of asking, you know, which almost might get to routine asking, you know, particularly for people who've got any of the indicators I said before. So that's depression, pregnancy complications, multiple physical symptoms, separated or divorced, socially isolated, homeless, and as I said, if you've already got a history of abuse. So then what can we do about it? As I said before, it's very simple what women say they want from you. They want you to be alert to signs and raise the issue. They want some posters in the environment, and I know that's hard in general practice. You've got posters for everything, and you've got the rainbow flag, and you've got the cultural things, but I think a poster really would alert a woman to the fact that this might be a useful place to disclose. Immediate response, they really want non-judgmental validation. Nobody deserves to be hit, you know, nobody should be experiencing what you are. Taking time to listen and address safety concerns, and I'll talk more about that. And understand this is a chronic problem. We, you know, have lots of chronic problems in general practice that we don't feel frustrated with, whereas we often feel quite frustrated if women don't leave, like you feel like they're going home to an unsafe situation. But really, they've had to deal with it for many, many years usually, and they're actually the experts in it, and you're there to assist them. And if we look at what interventions are effective in health settings, and we are updating this one as well, this Cochrane review, essentially advocacy and support works for women who've already sought help in shelters. Now that's different to our population, you know, who may not have even named it, and I'll talk more about that. And psychological interventions do work with these women. And mother and child work, which we have a dearth of in Melbourne, I don't know about, but actual work that works therapeutically with mothers and children, we find hard to find referrals to. So I trialled some of this type of idea, and we did screen in this one for women who are afraid of the partner in about 50 practices in Victoria, and we were trying to then educate the GPs and teach them brief, non-directive, supportive problem-solving counselling, and we did put up some posters and had a look at what effect that had. So we screened by bearing it within wanting to cut down on your smoking and feeling down, depressed or hopeless, physical activity, so that you know, it didn't stand out as being this is what we were doing. And we taught the GPs active listening exercises. All of us think that we're fantastic at listening until sometimes we see a video of ourselves or get reflections or feedback. Attitudinal exercises about how it feels to be a victim. We role-played different readiness for change, and we used survivors' voices. And I tried to model respectful behaviours, as did the other trainers. We focused on this model where essentially what we're trying to do is make women more aware of what's happening in their life as being damaging and damaging to their children, but without putting the blame on them, making them feel more self-efficacious by the support that we give them. And really, if they've got a lot of negative external factors, they haven't got any money, they haven't got anywhere to go, it's in some ways impossible for them to leave. So what we're also trying to do is maybe make baby steps for them to feel better and to make themselves, sometimes they want to stay in the relationship, but make it a bit safer and a bit better for what's happening. And there's small steps that can be done there. And so I see a lot of people who are not aware that, they have a problem or that it's strong belief that it's their fault, and you just connect it with the symptoms. So the next step is that they want to, they're just not sure whether they're, capable of making a change, and so you encourage the possibilities. And it was, I guess, in some sense, a bit of a relief finding out that it wasn't me, that these situations weren't normal. That's not how a relationship should be. The GP went through and I hadn't even thought of that, any of that kind of stuff. How to be able to get in the car and leave, make sure my car wasn't getting blocked, having my bag and my keys in a reachable pace that I didn't get trapped. So this is the sort of thing where they often feel safer if they have that sort of plan. And so when they're preparing to do something, respect whatever that is. It might be just telling someone in their family. It might be leaving. It might be taking out an intervention order. It might be doing yoga. It might be going back to work. It might be doing some education. All these things are steps along the way. And then they carry it out and, you should praise whatever they do. And often they do need to go back to the relationship because it's just, too difficult to be moving schools or moving, their resources are less. I realised when they became teenagers that I had to stand up to David, but just before that, I looked at the children and thought, they are looking because they are going to grow up believing this is the way it should work, and it can't be this way. I think it just slowly evolved that I just got stronger. And certainly teenagers are a very powerful turning point or time of change. And, the turning point might be something minor, like violence towards the pet, But that's not minor. But it can be something that on top of violence you think, you can't see why that's turned it around. So you really need to listen to them to try and find out what it is. And I teach also a basic safety plan. How safe does she feel? So her own judgment of her safety. And then your professional judgment is often based on, are there weapons? Are there threats of weapons? Has the violence been escalating? What type of violence it is? And does he have a drug or psychiatric history? And then a very simple safety plan. Most women, I don't have to do that on the first visit because that she discloses to me because she feels safe to go home. So you don't have to do everything in one visit. If she feels safe to go home and she's been managing it for years, you say to her, well, next time you come, we'll do a safety plan. And so the study I did where I taught all that actually improved depressive symptoms for women, but there wasn't any difference in the quality of life. But it increased the safety discussion with the GP about women and children, and the women felt more supported by the GPs and they felt more self-efficacious. So if GPs can do it, you can definitely do it. Sometimes have to apologise for being a GP in a nurse conference. And what we've done now is transferred this to an internet-based safety decision aid and healthy relationship tool because, of course, many women are not even accessing general practice. And if any of you got patients who you think would be able to participate in this trial, where it's open at the moment. And we called it a women's wellbeing project so that partners are not alerted to it. And we have 3 modules in it, which probably you can't read there. But one is about, is my relationship healthy? Am I safe? So it's got some danger assessment things in. And then about what their relationship priorities are, because they're weighing up their children, their resources, their love for their partner. There's all these things that they're weighing up in these safety decisions. And then we give them an action plan based on their answers and the 5 strategies. So at the moment we're trialling this. It's not available generally. So it would be for people who are afraid of their partner and who have experienced physical or emotional or sexual abuse And actually, we've now got 200 women signed up, so we need more, please. I also had so that's just a little bit of my own research. I also had the privilege of being on the World Health Organisation guidelines for responding to intimate partner violence and sexual violence in 2013. And we reviewed all the systematic review evidence. We looked at, we had an expert group around the table from all over the world, and we were really trying to come up with some simple guidelines that would work for all health professionals. And they ended up being reasonably simple. One is women-centred care, and I'll go through that in a bit more detail, that all of us should be trained in first-line response. We should all case find for the symptoms that I just talked about. Written information in private areas on the back of the toilet door or somewhere that women can access without having to walk across the room and grab a pamphlet. No, we couldn't find any evidence for mandatory reporting for domestic violence. That would, like obviously we have to report child abuse, but in fact we take the control away from women if we're trying to do mandatory reporting. Northern Territory is the only one where mandatory reporting is in, and that's because of the problem in Indigenous populations. And that mother-child interventions are good, and the psychological treatments. The women-centred care is really what I was talking about that we did in Weave. Non-judgmental, practical care and support that responds to concern, asking about the violence, providing information, assisting her to increase safety and providing or mobilising social support. And they've got a clinical handbook that's currently being trialled, and one of the summary of that first line response is lives, which is listen, inquire about needs, validate, enhance safety and support, which is things all of us can do. So I want you to think for a minute about what you could take away from this in terms of preventing and responding to domestic violence. I've got some resources up there. Some of them are Victorian. The college has done a lot of work in this area, and I'll show you that in a minute, and they've certainly got all the references to the resources that you might need on a website. And so the consensus guidelines are that it's common, has marked morbidity, and no evidence for screening, but really needing to respond to women. And the White Book has just been updated on the college website. It's accessible to everybody. There's also a domestic violence active learning module as well. And really, I think that I've got some collaborative opportunities here where I'd love you to think about referring the eye-to-side people. But also we're developing up interventions for children, and we're developing up interventions for men in general practice. So if anybody wants to talk to me about those. And this is a final survivor story. I wish my partner would control his mood and expectations of what the children and myself should be doing, that he would relax and not expect military-type obedience. I wish I had the courage to admit how unfulfilled I feel in this relationship and at times uncertain and scared. I wish that my family was more aware of the issues and that friends who do know knew how I really feel. What the GP did, she started to understand when I was coming in and I was sick and stressed, the feeling of being able to acknowledge that actually it was abuse. She encouraged me to take time for myself. I think because I'd been seeing the Weave GP for so many years, it made it a lot easier for me to open up. Just talking, allowing me to release built up emotions, reassurance and assistance in helping me understand why I've allowed the emotional abuse to continue. Life for me now is just becoming more enjoyable, actually having things to look forward to, not just trying to survive. I probably would have just kept plodding along with the way life was if I hadn't got the Weave invite. I still find the GP's probably my anchor, my centre point. She regularly keeps track of me. She's been my main focal point. The rest are just people that I see to help assist with getting through the journey. I hope I've inspired you today to assist women getting through the journey towards safety and healing for themselves and their children. I urge you to have a look at the White Book. It's got chapters on elder abuse, child sexual abuse, huge range of things, and has resources. The other this will go, you can all have access to this, but the other group that's got a great site is the Adult Surviving Child Abuse, and also the US National Centre on Domestic Violence, Trauma and Mental Health. And this is really what we summarised for the White Book. that any health practitioner needs to understand we have a role, we have to be ready to be open to recognise symptoms, respond to disclosures, assess risk and safety, review the patient for follow-up and support, refer appropriately, and reflect on our own attitudes and management of abuse. And finally, have respect for our patients, our colleagues and ourselves. If you're being bullied yourself, you can't do this work. So we need healthy practices to be able to do this work. So I'll end there, and I'm happy. I think I've got a bit of time for questions.
Certainly do.
Okay.
Any questions? Sure, you've got lots. Yes.
When some of the midwifery hospitals were doing screening for domestic violence like a few years ago, did that lead to good outcomes or not particularly?
Yeah, so certainly in New South Wales, they've done a lot of screening, and the World Health Organisation does say that pregnancy is a high risk and we should be screening in that setting, just because the pickup rate is very high. Now, some women find that we know, for example, in Victoria, that the maternal and child health nurses who see every new mother, they're mandated to screen as well, and we know that 20% of the women get screened. So there's a lot of, even though we might say, if I said to you all tomorrow, you must ask every woman, we're not all going to ask every woman, so there's a lot of barriers and things to that. And also women are spending their time judging whether you're trustworthy. So maybe they don't tell you. So some of them are not being asked, but some of them are also still not telling. Yeah.
I've got a question. Statistically, a very hard time for patients is when their partner retires. So they're used to doing all the shopping and the household chores, and suddenly he wants to do things with them or tell them which shop groceries. Have you actually statistically found a higher incidence at that point? Abuse?
Yeah, I think often transitions, pregnancy's one, probably retirement's another, but overall the prevalence is much higher in younger women. Yeah, elder abuse has a different flavour, and obviously it can be by carers other than the partner as well. In terms of certainly children are often the perpetrators in that sort of situation. So, and I think you've got to think to yourself, is that sort of control by itself, is that abuse or not? Is the woman then afraid of the partner? Is she, the combination of physical violence or threats of physical violence? And I mean, obviously it depends on the degree of control. But I think that's a transition and maybe a transition conflict, and you can still assist people with that. Yeah.
Was this just focused toward women? We were just talking before that violence occurs between same-sex couples and also violence from women to men.
You may have come in late. I certainly acknowledge that... no, that's all right, because I certainly acknowledge that it's in same sex, and I think it's probably got different dynamics and we need more research into that. There's certainly scattered through the White Book, there's stuff about same sex. I also acknowledge that men are victims, but women are certainly much more likely to be killed, to be injured, to have severity, much more likely to have that patriarchal terrorism stuff, the family terrorism stuff. So I think that I'm absolutely agreeing that it can be. And in fact, the same principles apply. What I've talked about with women can apply to men. Yeah.
With the federal budget and funding for domestic violence, I was listening to Malcolm Turnbull, and they were making excuses for how much they put into domestic violence, I think. But he tied it in with violence is increasing overall. Do you agree with that?
Yeah, look, there's... I don't think we've done the studies enough to link it to violence, and I think there's a group of men who use violence who are violent at home and also outside, and we're going to hear a little bit about drugs in a minute. I don't know where Jennifer's gone. And in fact, often that's connected with drugs and alcohol, and it's across the spectrum. Then there's a set of men who use violence who only do it in the home and don't do it outside. So I don't think we've nuanced the figures enough around that. And also sexual violence obviously is much more not connected to violence outside the home. Often the sexual violence is just against people in the home, women in the home. And also you've got to remember that domestic violence probably hasn't changed prevalence. We're just hearing about it more. That, we just open every paper today and it's there, but it's been around forever.
Jane?
Kelsey, you've got, when you talked about training, have you got any training courses or anything that you found that have been a benefit?
Yeah, so I certainly think that we've developed in combination, and this has been led by Jane Coles at Monash. She's actually developed up a online introductory course for medical, nursing, allied health students, and we've just been evaluating that, and that's actually going to be open access. So that's one that we do. The World Health Organisation's developing up a curriculum and wants to develop up some online modules. The College of GP one, as I said, has an online module, but I think that might be restricted to college members. Yeah, but you can all get access to the white book, and I think that you would find there's a lot of information there. I think that there was a phase where there was an extra PIP payment if you all got trained as primary care nurses. Is that still in existence? Anybody know? So there was a Relationships Australia and South Australia actually ran a one-day course on this. I think that there will be more training available. I left on your things our course that we offer at the primary care at University of Melbourne, and certainly it's woven into most of that because it's my area, and yeah.
Okay, and Samantha, you had a question?
I was just going to say that I've been doing a bit of work with young people in schools, and I've been using the Respectful Relationships toolkit, which is really good for the younger people.
Yes.
Is that Department of Education?
Yes. Yeah. So, I mean, this is obviously, which state she asked? Yeah.
Sorry.
No, that's okay.
This is obviously broader than just health, and in fact, gender attitudes and respectful relationships, and there's a lot of work being done by Our Watch, the Prevention Agency, and also White Ribbon. They've got some excellent training programs and things. And so, yes, I think that there needs to be a lot of work with young people as well.
Just with like the young people who are seeing sort of more specific violence, like sexting and using images as a power tool against partners.
Yeah, absolutely. Yeah, there's a lot more technological abuse. Yeah.
One more question,
Mandatory reporting for children.
Yes.
I know you focus mainly on ladies today, which is great. Situation where your neighbour, for example, you believe to be abusing the children verbally, emotionally, but you can't pin anything on it to ring and report them.
Yes.
What do you do in that situation? Because it's like absolutely soul destroying to hear the children being.
Yes, it's so sad, isn't it?
And on an ongoing day-to-day basis, all the time, where I find I have to take walks around the block, shut the windows. It's that bad.
Yes.
And I don't know whether I should be reporting them, and if I do, what do I say?
Yes.
What evidence do I give them?
Yeah. And I feel for you. And of course, it's very likely that the woman's being abused as well. There's a 50% overlay between direct child abuse. And in fact, in some definitions, witnessing the adult abuse is actually included in the definition. To answer your question, I mean, I'm incredibly frustrated when I see constellation of symptoms, small children who tell me they're being hit by their father, often in the context of domestic violence and separation and divorce and shared parenting, where 50% of the time they go to the dad. And I phone Child Protection Services in Victoria, and they are not interested at all if there's no injuries or any evidence of sexual violence. I'm not saying I think they're drowning. I think they're drowning. I don't know other people's experience. We should certainly, I reckon, have a whole thing on child abuse, maybe at the next APNA conference, because it's like a whole topic in itself. We've got, in Victoria, we've got Child First, which is for vulnerable families, and that's who I would ring. I don't know what state.
Queensland.
Yeah, I don't know whether there's an equivalent. I don't think there is in Queensland, but it's like a step before where you could ring someone and get some advice. The final thing is that we're developing up a health professional phone line as part of 1-800 RESPECT, which takes, which is a great place to, if you want to ring about getting some information and support. And you could ring and ask them, and they might be able to direct you in Queensland.
1-800 RESPECT.
Yeah, and it's got a fantastic website, and we're going to develop up a health professional line for that, for your queries about domestic and family violence. Yeah.
Thank you very much.